Charlotte has provided exceptional compassion, care and commitment to supporting a highly vulnerable lady who is pregnant and not engaging with care and support. Charlotte worked closely with the multi-agency team to attempt to ensure the safety of mother and unborn baby and developed a professional, trusting relationship which resulted in engagement with care and support. Charlotte visited this lady on a weekly basis to offer emotional support and antenatal care, despite the lady's non-attendance at critical appointments. Charlotte offered to request funding from social care for transport to appointments in the hospital for important scans and consultant review due to the lady having a poor financial situation, a chaotic lifestyle and no transport. Charlotte went above and beyond for the lady and her unborn baby and offered to escort her to her scans and consultant appointments for emotional support, which was gratefully accepted by the lady. Charlotte has managed both the midwifery and obstetric care aspect and the high-risk safeguarding for this lady and her unborn baby to an outstanding standard and should be commended for this. She is practiced with compassion, respect, accountability and excellence and is a credit to Wye Valley's maternity services. Charlotte has been an exceptional advocate for this lady and her baby and has continued this professional support and advocacy until discharge from the midwifery care to offer postnatal care and emotional support following the baby being removed to foster care. Charlotte has maintained excellent communication with the multi-agency team, which resulted in the safe birth of baby and a coordinated approach to support for the lady whilst in hospital and beyond. I feel that Charlotte is more than deserving of the Going the Extra Mile Recognition Award due to all of the reasons outlined above. Charlotte, that warms my heart. Our patient story this morning as a board was of a letter of complaint from a lady who had a miscarriage in her time with us. And so to have you as our Going the Extra Mile Award winner and such a wonderful nomination and to know you absolutely went the extra mile, on behalf of the board, we can't thank you enough. Thank you very much. Big round of applause.
Thank you. Thank you.
And get back into that home birth thing and enjoy the rest of your day.
Yes, I will. Thank you very much, everyone. Thank you.
Thank you. Take care.
Bye.
Oh, that's a heartening sort of Going the Extra Mile award winner. So, apologies for absence. I don't think we've got any now that Jane's back, having had her hip replaced since the board workshop. Any new declarations of interest? Please raise a digital hand. Okay, so the minutes of the meeting held on the 7th of April. If you have any amendments, would you please raise a digital hand? Okay, can't see any hands raised. So we then go to the action points arising, which is on page 20. And the first was on workforce. And Jeffrey and David to meet to discuss the Network Rail Wellbeing offer regarding line side landscaping. Sounds intriguing. That was done. Thank you, guys. And then on the mortality reports to be produced on a monthly basis, we've got that on the agenda. And then coming up on the next Freedom to Speak Up report, contain an update on the number of staff receiving feedback following raising issues. We'll come back to that in September. And then Jeffrey to review training for staff on pronouns and updating records across the trust. Jeffrey, where are we with that, please?
Yeah, that's work in progress, Russell. So we anticipate it's going to take us about 4 to 6 months because the ESR team and the EDI team, they're currently engaged in quite a lot of ongoing work. So probably it's going to take us about 4 to 6 months before we can resolve that.
Okay, we'll keep us brief, Jeffrey, because it's obviously something which is very topical. Are there any matters arising that colleagues think I have missed? Please raise a digital hand. Okay, Glenn, so I think it's over to you for the update and how you're seeing things. Glenn.
Thank you, Chairman. It's not in my report, but since we last met, in fact last week, the Health and Care Act gained royal assent, so we will be talking about that quite a lot more in future board meetings as we move forward to the July implementation date. But the first part of my report, and I referred to this verbally at our last meeting, relates to the Ocondone review of maternity services at Shrewsbury and Telford NHS Trust. It's not that far away from us. This second report was a very harrowing report, and I won't read out all of the content of my paragraphs there, but suffice to say there's really important learning from what happened there, and indeed other reviews of maternity services. There will sadly be some further reviews expected this year as well of services elsewhere in the country. As a result of this particular review, there are 60 local actions for that trust, but 15 immediate and essential actions for all maternity services, and we're already looking at those and implementing those recommendations, as indeed we did with the first Ocondone report. We will bring this back to many future board meetings to provide assurance on the quality and safety of our services. Delighted that we just had one of our midwives at this meeting to talk about the fantastic service that we offer locally. I think one of the important things for me in all of this is trying to ensure that we promote midwifery as a great profession and don't let some of these challenges put people off joining what is a very high risk specialty, but a very rewarding specialty. I then refer to infection prevention and control guidance. Nationally, this has been changing throughout the pandemic, but we had some residual guidance that was more relevant to earlier waves than the current wave. So that was updated nationally, but we took the view across the group to review and to use the flexibility that was included in the national review to change our guidance to ensure that we balance the risks associated with COVID with the risks associated with managing COVID, and we got to a situation where it was in many cases slowing us down and creating capacity concerns. So hopefully we've got the balance right. The details are set out at Appendix A. These will continue to be reviewed. One thing just to point out in there, the elective testing regime that's referenced in that appendix, it has been amended further, such that we're actually doing more testing than the guidelines would recommend. So just to make board members aware of that one. As I say, we'll continue to review the impact of these changes and future changes and ensure that we get the balance of risks right. There's then an update on the trust and system financial position. There's a really tough challenge for the NHS this year, alongside the recovery of services and the increase in urgent care demand, where we are trying to do more activity in all of our settings in order to address that recovery. That brings with it a cost within constraints of a national settlement that was it was one of the most generous, but also one of the most challenging in the context of what I've just described. So our system in Hereford and Worcester has been identified as needing to do better on our draft plans that were submitted a few weeks ago. We've been working through that, and we'll get a bit of an update from Katie later on it. The current position that we have committed to is just over a £27 million deficit. What I would emphasise in all of that is prior to COVID, we did some work to look at the structural deficit associated with running services in a very rural county like we do, on the scale that we do. And we thought through that work, there's probably about 20 to 25 million pounds of extra cost compared to other systems. So being at just over 27 million is getting us down towards that figure. And what we obviously will aim to do is to arrive at a situation where we can firstly agree what is an appropriate level of funding for our service, but then also make sure that we deliver the efficiencies to get down to that level. And we've made some good progress on that. There's then an update from our integrated care division, and we spent some time this morning at workshop looking at some of the urgent care transformation that's going on in out of hospital services, which is a really important part of our organisation. I mean, some quite interesting stats here that 6% of the over 65 practice population is on the district nursing caseload, which was quite a surprise for me. So quite high volumes of activity compared to the national mean, and therefore using a new safer staffing tool to get the balance right, but also looking at how we can innovate in order to manage that really high workload associated with our ageing population. Good news, though, in the middle of that is the movement from having vacancies at 20% in the kind of largest team to having no vacancies at all. So well done to the division for recruiting and developing the new roles that we've described there. And so, and at the end, we've got Charlotte's employee of the month wording, which just spoke to her about that actually before we started the meeting, and I think we have missed a trick that it's the Yorkshire midwives on TV rather than the Herefordshire one. So we'll see what we can do about that in the long run. Happy to take any questions.
Thank you very much, Glenn. And it's always worth, as you refer to the rurality issue we have on the numbers, to remind members of the public that we do pay about £25 million a year for the PFI contract that we're in. Questions and perspectives to Glenn. Richard?
Thank you, Glenn. Thank you, Russell. The Bank of England is projecting that inflation is going to reach 12% later this year. Medical inflation is higher. Presumably, this is going to have a big impact on how far our resources will go. And therefore, our financial plans and projections.
Yeah, good point. And they've just put interest rates up today as well. So, yeah, the way that we've modelled our costs for this year, we try to ensure across the NHS that everyone uses the same parameters, because they're quite hard to predict. And in fact, the predictions we were looking at in February, the Bank of England have now updated those and have raised the inflation. So there potentially is an understatement of inflation in our numbers, but our numbers are consistent with the modelling that all other trusts have included. And if inflation goes up to those high rates, I am expecting the national team to negotiate something with the Treasury to compensate for that. The other thing that's in our modelling is an assumption, and again a big assumption, that COVID will not be impacting on our cost base beyond the end of quarter one, and that's in our assumptions also. And both of those things could add cost to our system. So we'll go through the detail of that later on in the meeting, but it's really important for us to be aware of what assumptions we've made as we do that modelling.
Yeah, I think it's almost inevitable, Richard, isn't it, that the numbers are going to be much worse because of inflation alone. And Ian?
Thank you, Chair. Yes, really positive to see the update on the community nursing service, Glenn, and very helpful to have the figures there showing activity levels something like 20% higher in Herefordshire than they are compared to the national average. And the real credit, actually, I'm just noting the success we've had in recruiting to vacancies, which is almost bucking the trend a bit in terms of recruitment and vacancies. And I wonder whether there was anything we can learn from that in terms of the success of that campaign.
Do we want to hold that Ian, for Jeffrey's report? I think an absolutely key question, but I think it would be good to hear Jeffrey in particular sort of picking up on that. So Jeffrey, can you make sure you pick up on Ian's question? But
so Jeffrey,
good idea, thanks.
Yeah, Jeffrey will get the credit for that one then, Ian. So yeah, enjoy that later, Jeffrey. But no, we are one of the biggest challenges that the NHS faces now is turning the allocation into staff. and that will not be easy. And the biggest challenge areas are often those out of hospital ones. So we have bucked the trend on that, and it is important that we look at the learning from that. It's a great place to live and to work, of course, but and our staff survey has shown that we are a good employer. But yeah, let's make sure that we get to the bottom of that and do lots more of it as we move forward, because there's still some areas of the organisation that are more challenged.
No, absolutely. And Richard in the chat box reminding us that some of us lived through the 70s. Thank you, Richard. Glory years, the 1970s. Slade, Jimi Hendrix, the days to remember. But inflation did get absolutely ridiculous, and I remember when interest rates went up to 15%. It was quite a shock to one's mortgage payments. So if there are no further questions, Glenn, we're getting to the detail of the integrated performance report and dashboard. So Jane, do you want to do the introduction, please?
Yeah, I will do. I also can't believe you didn't mention Pink Floyd, but I'm sure you'll reflect on that. So when I wrote this, which was only a week ago, we continued to be in a very difficult place, although things look like they were just starting to turn, and it does look like we have got some really positive green shoots that we're experiencing now. I will talk a little bit though about what I put in the report, because what really forced us into that circuit break action, which we did just before Easter, and really what that meant was we stopped all of our elective operating that wasn't cancer or emergency for a couple of weeks, and redirected that resource into managing our flow. Number of drivers for that, which I've put in the report. But we did have a really very impressive response from the organisation, from our clinical teams that responded to that. And the big driver was ambulance turnaround times, not quite out of control, but really extended, which just means that's a danger to the public, and we've got a responsibility to help to manage that. So an amazing response, and that really did turn things around. That was in our services, our acute and community services, but also our partners. I mean, the council did an awful lot to support the movement of some patients who are waiting for care at home into some spare nursing home, residential home capacity, which again really helped to get our emergency patients nearer to in their footprint. So a really good response. And but obviously we lost 2 weeks of elective operations. There's a high cost to that to our patients. But since then, we have now been able to ring fence our day case unit again. A team ward is ring fenced. We've got our orthopaedic operating out of our small 8-bedded women's unit. And by the end of this week, we should have flipped that into Gilwan, which doubles the size of the orthopaedic bed. So that really gives us the plan that we wanted in terms of ring-fenced elective capacity. So what's changing to deliver that, I think, is 2 things. One is COVID has started to reduce very significantly. When I wrote this report, I think we had about 60 inpatients with COVID. Now, most of those weren't unwell with COVID, but the infection prevention measures we had to take to protect other patients from getting it meant that lots of patients had to move lots of wards, and that just reduced continuity, and their clinical team wasn't able to progress them in the way they would be able to. So we had a really big length of stay increase. So COVID's down. It was 16 this morning. So yeah, 75% drop in the last about 10 days or so. And what that's meant is we've now been able to move away from having COVID specific wards, almost treating COVID as a specialty, so that patients with COVID are on their specialty wards, and our operating principle now is to keep them on the ward unless there's a clinical reason not to. So that will give us a continued improvement in the way our teams can be effective and efficient. So a much better position than we were even a week ago when I wrote the report. The other thing we did as part of that, and we heard some of this in the workshop this morning, is we've also put back in place a trauma-specific ward. So our plan had been to have a large ward which had, in effect, all of our emergency surgical activity, trauma, surgery, and gynecology emergencies as well. That wasn't working particularly well. So I think it's fair to say we've listened carefully to staff who were concerned, and we've moved back to having a trauma-specific ward. So it's changed the original plan that we had, but it's the right change. And all of those teams, in fact, I went to see the team on Froome at lunchtime, and they reported they were much happier with 2 specialties on the ward rather than 3. It was just too complicated, I think, for the nursing staff to manage. So a number of changes and a number of improvements. Just a couple of things I probably wanted to mention on top of that. So one was around that recruitment challenge. And so we have, so healthcare assistants, I've said a couple of times before, we're really concerned about. So we have recruited strongly over the past few weeks, and we've had numbers of new healthcare assistants starting. That's great, but what we need to do is to retain them. And what we will be looking at as a trust management board in the next couple of weeks is a career progression framework, which means for our healthcare assistants starting with us, we can put them through a training programme, and then they can move through the pay grade a little bit more easily. So that's great for people getting more training, more support, but also they've started on a career pathway, and that really hasn't been the way the healthcare assistant workforce has experienced that right from the very beginning. So that's an important change that we're going to make. And as Richard was just saying about sort of cost of living and inflation, we also have to do something to help our staff with that. So an important piece of work, and that will go to Trust Management Board in the next couple of weeks. The other important thing to say, we talked here a number of times about Home First and the recruitment into Home First, and so the pay rise and the adverts have gone out, and I had a very excited text from the manager last night saying we recruited 9 today, and 4 of them are starting Monday, which was fantastic. And there's something for us to learn there, Jeffrey, around pace from recruitment to actually starting in the organisation. But I mean, that's a 64 whole-time equivalents in that service, and we were running at 30. So 25% we've already got those staff in place. So that's been very important. So really good to start to see that coming through. Last thing I wanted to say really was I've noticed a few things about it's been a tough year, but we've made some really solid progress in a number of areas. So I've noted those in my report, and it's just a good time, I think, at this time of year when we're looking back on the whole of the last year, really just to thank staff. There's been some pretty extraordinary efforts. Circuit break was one, but there's been lots over the course of the year. So a really good time to thank our staff for all of their efforts.
Well said, Jane, and it is really great to see the agility in the organisation to respond to events. And Andy, it's been, I know you've always been involved, but it's been a bit of a baptism of fire for you as well, so very well done. Any questions to Jane, or should we dive into the detail? Richard?
Yeah, I just wanted to share something with the board. In the last couple of weeks, I've been approached by 3 members of my local community here in southwest Herefordshire who wanted to tell me how impressed they were with the quality and the efficiency and the skill of the interventions they'd had at the county. I think all 3 were on the 2-week cancer pathway. And I know that the plural of anecdote is not evidence, but even so, I think it is fantastic that we can receive that testimony at such a tough time, and it reflects so well on everybody that's been involved in efforts to keep the show on the road in recent weeks. So well done, everybody, for that.
Thank you, Richard, and that's great to hear. Andrew?
Yeah, I was interested in the 50% increase in discharges around about Easter time, and really positive, creates a space over Easter. But on the other hand, you could see it as untapped opportunity from the normal activity of the trust, and in many ways supports the internal work that's been done in the urgent care pathways that we described this morning.
Yeah, if I could just comment that that's right, Andrew. But it is on the backdrop of lots of medical patients everywhere, and part of that is that sort of continual movement around of patients, and so the lack of their pathway. And so I mean, what we did with that diverted resource, so we had our junior doctors from orthopedics and other who were going out supporting those wards to try and make that different. It's not sustainable. We can't operate in that sort of emergency way in the longer term. So it was a great effort, and hopefully it is the thing that's flipped us back into normal operating. So now we've got COVID is coming under control. I think we've got a great opportunity to really motor on with the transformation programme that we were hearing about this morning.
Okay, great. Thank you, Jane. Thank you, Andrew. Okay, given Jane's comprehensive introduction, and we are running a few minutes late, can I ask executive directors just to pull out the key points that they want to emphasise, and assume the board papers are read. So on quality, Lucy?
Certainly, thank you, Chair. I can certainly do that because Glenn and Jane have covered most of what I wanted to say. But very briefly, the Chief Nursing Officer from Taurus Healthcare and myself went to the Herefordshire Clinical Practitioner Forum a couple of weeks ago to present around us wanting to establish this learning forum across partners across Herefordshire, particularly when you want to learn from when things don't go so well, so from incidents and complaints. That was received well by the Clinical Practitioner Forum, and we aim to run our first learning forum for Herefordshire on the 26th of May. And I'll provide feedback on that at future meetings. We continue to be an outlier for mixed sex breaches nationally, and that is driven by the COVID measures that we're having to take with infection prevention and control. We had reported at board last month that we'd had a fortnight of no mixed sex breaches on our acute medical unit at all. But unfortunately, due to having high incidence of COVID, as Jane referred to, we had lots of COVID positive patients within our emergency department that needed to come onto the acute medical unit, and they often were of the wrong sex, which meant we had mixed sex breaches. We continue to focus on mixed sex breaches in our operational discussions and are hoping to get back to that hard stop that we'd introduced previously. We've introduced order sets, which is part of our antimicrobial stewardship arrangements, which is to make sure that when patients need antibiotics, that they get the right antibiotics, the best antibiotic for the infection that they have, and for the right duration. So they were launched just after the bank holiday weekend, and they're part of our aim to reduce clostridioid infections, for which we are also an outlier. Glenn has already alluded to the infection prevention guidance changes that we made in advance of the Easter weekend, and ahead of the national guidance, we adopted some of the regional principles, and they were absolutely essential in terms of managing the impact of the 3 outbreaks that I refer to in my paper. But then we had a number where I came back to 6 wards closed with outbreaks post the Easter weekend. And Jane's already alluded to it, that led to significant poor patient experience, essentially multiple moves, increased length of stay, poor continuity of care, and other matters. So that new guidance and going early with that guidance ahead of the Easter weekend just made things operationally a little easier. Staffing, we've already alluded to, has been a continued challenge for the last month, particularly around many of those ward changes that are described in my paper, where surgical wards became medical wards to manage that urgent care pressures that we were seeing. And that does lead to staff dissatisfaction, because if you choose to be a surgical nurse, you choose to be a surgical nurse. And I'm pleased to say that in May we are seeing an improving picture, both in terms of sickness and then settling our wards and making sure our wards are the wards that they need to be, the specialty they need to be, and then we can put the staff where they need to be, which will improve their experience. But some of the improvements we've seen in May related to staffing has been because of new arrangements with our agency provider, so they're not without financial consequence. And that's all I wanted to cover. Thank you, Chair.
Thank you, Lucy. Clearly very, very busy times. Questions or perspectives to Lucy? I mean, clearly, Lucy, in terms of agency usage, the ED is still the area which is hottest. If you can just continue to keep us briefed on that as the months develop, that would be good. Okay, so we'll move on then to Andrew. And Andy, over to you on the operational activity update.
Thank you, Chair. Just as you said, take the paper as read, just 3 points I want to raise the board's awareness of. And firstly is our 104-week elective activity plan. So that is the plan to treat all our patients that have been waiting over 104 weeks, 2 years, to get that down to 0 by the end of June. It's not just that cohort of patients that we are operationally looking at the moment, it's also the at-risk group for July. So those patients that would tip over into 104 weeks during July, we're aiming to get treated by the end of June. Our 2 biggest risk areas are respiratory and T&O. In respiratory, awful lot of work has gone on there. They've halved their 104-week position over the last 6 weeks. The main success there is their revised bed base and the ability to release more consultant PAs into elective activity, and the success in some of our insourcing that is eaten into that backlog, and we hope to get that trajectory for respiratory resolved before we get even to June. We're hoping to get that resolved within this month. Our biggest challenge is T&O and the large volume of elective operating that's required for T&O. Jane's already mentioned the challenges we've had over the Easter period and how our circuit breaker actions for Easter is eaten into our elective bed base. But as Jane's already alluded to, the recovery has been relatively swift and continues to be swift. And over the next couple of weeks, we intend, or for next week, we intend to get a 16-bedded or clean orthopaedic ward to increase our operating, and then after the week after to restore our remaining 10 elective beds. So by mid-May, we've got all our elective beds up and running. Along with that, we have insourcing, outsourcing and mutual aid through Swift, and outsourcing through the Spires at Worcester and the Nuffield locally. We have a very detailed operational plan to get all our patients that are waiting 2 years treated by the end of June. There is risk within that, but that we are monitoring and reviewing on a daily basis, and we have every confidence that if our plans are deliver, that those patients will be treated ahead of the June ask. Secondly, just want to raise around urgent and emergency care. Jane has already alluded to the challenges over Easter, and the board workshop this morning has already highlighted to the board the transformational work that John Barnes is leading. But just wanted to flag the SDEC performance, same day emergency care performance. So our overall adult admissions for both 0 length of stay and greater than 0 length of stay is now at the same level of activity or same level as demand as pre-pandemic levels in Q4 of 2019. But our greater than 0 length of stay patients is 23% less, and a big proportion of that of managing those patients through a same day emergency pathway is our SDEC provision, which last month performed at just shy of 46%. And lastly, just wanted to flag our stroke performance yet again. Like Jane, reflecting on the last year, despite the challenges the stroke team have had with absence, outbreaks on their ward, we have seen an improvement in our hyperacute stroke KPIs this year compared to 19, 20 and 6 of the 9 areas. Particularly pleasing is the percentage of patients seen by a stroke specialist in 30 minutes and the percentage of time our patients are spending on the stroke unit. But not only that, our TIA performance, which for 1920, the percentage of patients that were treated within 24 hours was at 31%. We've ended the year at 56%. So despite those COVID challenges, the teams have stepped up and improved our performance with stroke. So that's a real cause for celebration. That's it. Thank you, Chair.
Thank you, Andy. Any questions for Andrew? Glenn?
So firstly, really well done on the stroke indicators and the SDEC numbers. They're probably, those SDEC numbers are probably best across the group at the moment. So that's really good going. Just wanted to say thanks to our colleagues at Swift for helping us with the mutual aid, but probably more importantly for the public actually to thank them for taking up those offers of being treated slightly further afield from normal, and that's something we will. We'll need a little bit of flexibility from the population on, but so travelling to Warwick for your orthopaedic surgery, it's been great to see the take up of that, and I will make sure that you're cared for well if you take up those offers. Any more members of the public watching, but it's really important for us to continue to drive down those long waiting times. So thanks for your efforts on that, Andy. Yeah,
no, I think we are very conscious, aren't we, team, about the need to drive down the waiting lists. Just before I go, Andrew, your hand went down. So just for clarity, Andy Parker, what's our 18-week RTT number like? Because I do want us to not lose sight of that as a key metric, because it's relevant to our patients. Do you have that to hand or not?
Off the top of my head, I believe the March position ended up at 66%. But I can give you that precisely outside of the meeting, Russell. Okay,
that'd be great, Andy. But I would like us just to have it in our conscience every board meeting, because it is a key metric, and I want us to be getting back up above the 90, you know, as a medium-term objective. If there are no more questions to Andy, we'll move on then to allow Jeffrey to take the rightful glory for those recruitment numbers that Glenn was trying to poach. So Jeffrey, how are things on the workforce side? And if you can pick up Ian's question along with your summary, that would be good.
My apologies, I had to unmute myself, but thanks, Russell. Well, we continue to experience significant challenges in meeting our workforce KPIs, and sickness absence, unfortunately, continues to be high within the organization, but this is really down to COVID-related absence and mental health conditions. However, the good news is that we're now starting to see a reduction in sickness absence, and that should really be the case over the next few weeks. So we had a very successful workshop with managers last week, which I conducted, and following that workshop, we're going to be making some changes to our policy and protocol. So putting in some more additional support for line managers and also employees who are experiencing difficulties in the workplace. So we will be doing some changes just to try and drive down sickness absence. And also, as we are seeing a reduction in COVID cases, that's going to free up management capacity to try and work with the HR teams over the next 4 to 6 months, so we can then start turning around those KPIs. In terms of the recruitment and retention challenges, I mean, obviously, we're doing a number of things as captured within my paper, including international recruitment and all the other things we're trying to put in place. But recently, we've also gone live with the recruitment campaign with Hoopul, as Jane mentioned, and we're now seeing some growing interest in some of our vacancies, certainly at the support worker level, which is where we got a real concern in the clinical areas. So we carrying on with international recruitment, but this recruitment campaign that we've now launched will run over the next few months. And we believe that with the developments with the home first side of things, as Jane mentioned, and with a number of other things we're putting in place, we should then start addressing and filling the vacancies that we have. In addition to that, we've also invited 2 of our non-exec directors, Ian and Nicolette, to join us in our recruitment and retention working group. And the intention behind that is for us to make sure that we explore in every avenue possible to try and not just recruit staff, but also to retain staff. Because it's very important that when you think along the lines of what can we do differently, it comes back to creating the right environment, the right culture. So the line managers and senior staff in departments are key to this. So trying to create that sense of belonging and also giving people scope for career progression and flexible working. So from the analysis we've been doing over the last few months in terms of exit interviews, new starter surveys, it's very clear to us that we could do a lot more in terms of expanding the flexible working options that we have. and more importantly, making people feel welcomed and supported in the departments. So we're putting things in place to do that, and we believe that those things will bear fruition over the next few months in terms of how we try and retain staff. So lots of work going on, trying to turn around the KPIs, and also we're still progressing the equality and diversity angle as well. Next week, for instance, we're going to be promoting Equality and Human Rights Week, in addition to the Mental Health Awareness Week that we are also progressing. So those are some of the key summary points from our report, Russell. Happy to take any questions.
Thank you, Jeffrey. Questions and perspectives to Jeffrey. Andrew?
Yeah, just well, it's self-evident, I suppose. The position looks very difficult, but I was wondering whether you've got any sort of projections as to when we might see the vacancy levels start to come down.
Yeah,
they've been at sort of 300-ish for, well, probably since July, or no, June last year.
Yeah.
When could we start to see those falling?
I would say we're looking at by October, November time, and that has got to do with the projection that we have to try and speed up and bring in more international staff over the coming months, and also support workers, because a lot of the vacancies we have are to do with the clinical areas, so nurses, doctors, and also support worker retention. So some of the things we put it in place, I believe by October time, we should start really seeing a real reduction in those numbers.
Great, thank you, Jeffrey. Let's hope we do see the numbers turn. Ian?
Great to see we're developing a career progression framework, Jeffrey, for our Band 2 support workers. And the report says within 4 months. And my instinctive reaction to that was, can't we go quicker than that in terms of getting that in place? Or, I suppose a supplementary question is, I can see it may take 4 months to get it fully implemented, but I assume we're signalling our intention to do that, because actually, obviously, we've got a problem right now. So our Band 2's been able to see that actually things are in the pipeline is one way of actually trying to retain them at the moment. So it's that.
Yeah.
If you get my question.
Well, absolutely, yeah, and certainly that is the intention. As Jane mentioned, we're taking something to Trust Management Board in the next few weeks. So the intention will be that certainly maybe by June time, we can start pushing this through. But the 4 months period is just something that just gives us a scope in case we've got to develop some more frameworks. But the intention will be to do that as quickly as possible.
Better done than perfect, Jeffrey. Remember that mantra, better done than perfect. And as Ian encourages, let's get the pace going. Lucy?
I just wanted to add that our vacancy position for registered nurses is heavily reliant on international recruitment, and we do have that business case for 110 that we'd initially intended to bring in by October. There is, however, a national issue with OSCE examination places. So we're just recasting our predictions around vacancies being filled and vacancy factor, given that there are no OSCE centre places available for nurses to sit their exams until July, August of this year. So we are going to bring a deep dive back to Quality Committee on the nurse and healthcare support worker vacancy position to the end of May Quality Committee, and I'm happy to share that with board members too. And just to go back to the City District Nursing team, that was down to leadership in terms of turning that vacancy factor around in that City District Nursing team.
Thank you, Lucy. And Grace?
Thank you, Chair. Jeffrey, thank you for all your hard work on this. And just in terms of the psychological and team wellbeing support that you mentioned, do you have any data or info on what the uptake on those services is?
Right, we had to pause those over the last few months, so we're going to be restarting those in June, but it was really well attended. So by the time we paused the sessions, we had about, I think it was about 54 employees who were attended so far in different teams, but we will be kicking that back off from June onwards.
Okay, thank you.
Good level of demand, obviously, Jeffrey. Just a quick question from me. I'd like us to think about what support we give to women who are pre-menopausal or menopausal. I know it's a very popular issue at the moment, but it's just a fact of life for half or over half of our workforce. It's difficult to not come across as having a limited view of the issue as a man, but it does seem to me that it would be a worthwhile discussion, maybe for you and Jane to have, about what extra support we can give women who work for us, who are facing practical issues which might be affecting their own well-being and productivity as they live with the consequences of the menopause. So if we can just take that up outside. I've encouraged at Swift and George Eliot, as we have networks for BAME and disability and LGBTQ+, we might consider having a network there for women who are suffering from the challenges of being pre or actual menopausal. You might want to consider the same thing. Dangerous territory for a man to talk about, but it's done with the best of intention. Colleagues, happy to move on? So, Katie, tell us about the money.
Thank you, Chair. So I'll just summarise what the report is telling us in terms of how we closed the financial year. So the report reflects the period up until the end of March 22 and therefore the full financial year just gone. In terms of income and expenditure, we delivered a year-end outturn surplus position of £1.5 million. That's subject to the audit process, which is underway, but we wouldn't expect that to change materially as a result. And it is broadly in line with where we expected to be based on our reforecasting over recent months. So, of course, it's pleasing to have finished with a small surplus, but what we shouldn't forget, of course, is that our cost run rates do remain high, particularly around agency staffing levels, as we've just reflected on in terms of operational and workforce pressures. And also a large proportion of the cost improvements delivered in year were non-recurrent, which, of course, creates an ongoing pressure into 22-23. As Glenn alluded to earlier, we have an underlying position, which is a deficit position. So as we come out of the COVID financing arrangements, we move back into a world more akin to that prior to COVID and needing to deal with our deficit. In terms of capital and cash, we spent £18.6 million on capital in the year. Despite our concerted focus over the months leading up to year end, we did experience some delays in the supply chain and therefore saw a small underspend at year end against our business as usual allocation and some small underspends around timing to do with national programmes. But by and large, we spent what we intended to do. From a cash perspective, balances remain stable and our prompt payment statistics are also stable, albeit slightly below the target, which the team are working hard to improve on. And really just to say, of course, the focus and energy is now on 22-23 and delivering the operational plan, which, as Glenn described earlier, is not without risk. And I know there's a paper later on in the agenda.
Thank you very much, Katie. Questions or perspectives to Katie? Katie, it's really great the clarity you bring to the discussions on finance, and it is extremely helpful. But clearly the year ahead, not just with the inflation challenges, but the productivity and ring fencing challenges we have in Elective are going to be key to get right. So thank you. Colleagues, happy to move on? So on to the One Herefordshire Plan. Jane, which we've discussed in different forum as a board before. What would you care to emphasise before we go for approval?
Yes, I wasn't going to say very much about this other than it's a really important next step and an exciting one, and it's building on what we did through the transition board and then the first year of the One Herefordshire partnership. So this is about the plan for the next stage of our sort of place-based journey. So this has been agreed at the One Herefordshire partnership and is now with all the various partners, boards and senior teams for their endorsement. But wasn't going to say any more than that. As you say, we've well rehearsed this. Other than to a particular thank you to Alan on this, actually, who's pulled this together from a very complex set of discussions and lots of people involved. So particularly thank you to Alan for pulling it together.
No, thank you, Alan. I'd endorse that. Really good work on it. Any questions to Jane on the One Herefordshire Plan, which, as we know, we've discussed a number of times as a board. Chris?
Thank you, Chair. We had some discussions about the quality oversight and the guidance received nationally. We did a little bit of pushback on that internally before you put this paper together. Has there been an endorsement from the ICS for that approach?
It's after it's been through the Herefordshire partners, the next stage is for it to go to the ICS executive or the ICB, depending on whether we're in June or July by then. So I guess that's the point of sign off. But I think I'm pretty confident, and Lucy will let me know if I'm wrong, that there's that the approach we've taken is one that's supported, and there's a lot for us to all work through and understand around how we're going to have quality oversight through ICSs, and the starting small, building on the things that we know work, and not trying to be too complicated and to reduce duplication as much as possible. I think those are principles that everybody is signed up to. So I'm reasonably confident this will be supported.
That's good news. Thank you.
And to be honest, Chris, I wouldn't want to dilute our responsibility for quality as an organisation. I think you get into dangerous territory then. I know you'd endorse that. Ian?
Thanks, yes. I mean, some fantastic work around One Herefordshire Partnership, I think. The one little bit of challenge I'd want to perhaps make in terms of where we take this next is around the notion of co-production and the involvement of our citizens. It still reads as a very service-centric document, and I know that it's developed incrementally over time. And that's the bit that for me is not quite there, and I know it's part of our aspiration, and in my sense it almost could be we could kind of move it from where we are, which is brilliant, to something which is absolutely outstanding, I think, if we were able to frame it in terms of local citizens and within that notion of co-production. So something I think to consider in terms of where we take this next.
I really agree, Ian. We've made a start on some of those things, but we've got further to go. But I think the community partnership forum we've got as part of the arrangements, it's being led really well by Healthwatch and Christine Price, the chief executive of Healthwatch locally. So I think we've all got really quite a lot of faith that we've got the right structure to do that. We just need to do more of it now.
Thank you, Ian. And finally, Richard.
Yeah, thanks, Jane. Good report. My question is about the refreshed integrated care strategy, and in developing that, how have we assessed the performance of the existing integrated care strategy in terms of what it's done for use of resources, for outcomes for people, and for people's experience of joined up health and social care?
Oh, that's a really good question. I mean, I guess in a way it's across all of those metrics that are, some of them live with us, some of them are a bit disparate, but it's no doubt that it's been I mean, we haven't changed too much on them. It's really the strategic principles pretty much that have changed on it and just been refreshed. There's no doubt that as a document on a single piece of paper, just trying to pull this together and provide an explanation to all of our staff and to the public, it's something that has got some traction, and it has been a guide for the way that we've started to pull things together. So I guess the next phase, particularly around the aims of the ICS and the aims of the Health and Wellbeing Board and the aims of the One Herefordshire Partnership, we do need to get much cuter at measuring those things, and certainly the ICS, there's quite a lot of work going into that, and for us locally as well. So I think we need to get smarter at measuring that. Certainly through ICE, there's very much a role for ICE to be holding the ring on that. And then the other thing is, as part of the governance changes that we've made through this is that we are going to have this quarterly sort of performance review of Herefordshire. And again, we're going to start relatively small with that, with a few indicators, rather than trying to do something too big and too complicated. And we'll build that as we go. But it's an extended membership, so members of ICE will be invited as part of that quarterly review. So I'd say there's lots more for us to do. I guess the other thing I'd say is some of those things have got they're a slow burn, aren't they? Dealing with childhood obesity, looking at it once every quarter, you're probably not going to see it change very much. So there is also something about how we use the JSNA in a better way than I think we have, and that we all pay more attention to it, and probably that it's a better document. I mean, it was interesting when Russell and I were at an ICF executive meeting last week, and there was some data in there about infant mortality in Herefordshire, which came as a surprise to me, and it should have been in our JSNA, and it wasn't. So I think it's around developing the JSNA so that at least once a year we're having a look at the outcomes on the things that we're doing. So I guess what I'd say is lots more work to do, but I do think it's been a really good guide for the way we've developed so far.
Thank you.
I think just adding to Jane's points, I think it's a really good challenge, Richard. I do worry greatly that some ICSs, and I see it in other parts of the country, aren't focusing enough on transforming into an integrated care way of working and an integrated care system. I think one of the successes at Hereford and Worcester has been an agreement on the fact that that's primarily what we're all trying to achieve. And a real focus on place as, if you like, the focus for the delivery of that. I think the other real positive is that in terms of executive leadership, I think the ICS, ICB executive team get the fact that they aren't the old CCG, that they need to encourage different ways of working and to be flexible in ensuring that they facilitate that happen. So my sense is we've got the right building blocks to start to do the sensible stuff that needs to happen if we're going to deliver left shift and enable people in Hereford and Worcestershire by extension to live longer, happier and healthier lives. I am far less confident that other ICSs have got the building blocks in place to do the same. And are in danger of becoming mini strategic health authorities and just another layer of bureaucracy in the NHS. Richard, did you want to come back on that?
Just a very quick comeback, Russell. And the reason I raise it is that I think it's really important for our confidence as an organisation and our system partners that we can demonstrate some tangible evidence that we are getting results, that it's no longer enough to say, oh, we get on really well. We're not running a country club here, and having some numbers around our achievements and all the work that's going into this, I think is really, really important. But thank you for that.
Nicola, and then we'll move on.
Yeah, it was just a quick observation. We'll actually build on what you just said there, Richard. And I think it's not just about the numbers, but I think now following those building blocks, following where we are, just some narrative and some stories and sharing that success will bring it to life so that we really understand what it means. And I think that will help us see it in a much more three-dimensional sort of effective delivery mechanism. So which I think is probably what Richard was saying, really, but just an observation.
Yeah, I think there's no question we're probably, we are 18 months behind where we would have been if we hadn't had COVID. And so now's the time that we need to start to push to deliver. So team, we need to approve this. If you're not happy to approve the One Herefordshire Plan, please raise a digital hand. Okay, duly approved. Thank you very much. And thanks for your hard work behind the scenes on that, Jane and Alan. And then we've got the Foundation Group Strategy Committee terms of reference, really just for awareness, which allows, in terms of terms of reference, the changes relating to associate membership in the main. Any questions on those? Okay, if you're not happy to approve, please raise a digital hand. Okay, duly approved. Thank you. So we'll move then on to the mortality report. David.
Thanks, Russell. Just briefly, yeah, you'll recall I alerted the board to a significant increase in our mortality, but thought it was to do with the COVID surges that we were suffering. I'm glad and predicted that it would come down. I'm glad to say that's the case. So actually, since this report was released, we've had the national 12-month rolling figures up until December last year, and we're now back into the normal range. Particularly pleased to report the reduction in sepsis deaths. These are one of our outlier groups still, and it makes you wonder how more improvement we can get with the necrophema statistics, but we've had improvement again on this in this month. I thought I would tease out that infant mortality statistic that we just recently became aware of. It's a relatively historic figure, but our current figures for extended perinatal mortality remain reassuringly low and on the trajectory to meet the 2025 deadline for reducing perinatal mortality by 50%. Russell, thank you.
Okay, that's great, Dave. That last point's incredibly important, given that the UK is 27th out of 38 countries in the OECD on infant mortality. Any questions to David on that assuring shift in the numbers on mortality? Okay, thank you. And I assume Chris is still working, David, on the mortality work, or has Chris moved off that project?
No, he's supporting me admirably and firing on all cylinders.
Okay, great. Can you say thank Chris on behalf of the board? It's great having firing on all cylinders in the way you describe. We'll move on then to the financial plan update, which you teased us with earlier, Katie. Over to you.
Thank you, Chair, and it is just a short update paper this month. So colleagues will recall that when we approved the financial plan last month, we did anticipate some further improvements ahead of the submission date, which was the 28th of April, and we'd requested delegated authority to the CEO to enact that. So just as an update in terms of what's happened since we met a month ago, we've reviewed those core assumptions and along with system partners and the regulator, explored mitigations to reduce that deficit, as Glenn alluded to earlier, in terms of the system position not being acceptable at that time. As a result of that process, we had sufficient confidence to make a small number of positive changes to the financial plan, primarily around our income assumptions. And you'll recall that we'd last month described a number of our contracts as still not quite yet finalised, which is where some of that movement has appeared. And that results in the final deficit plan that we alluded to earlier of £27.1 million. The plan, as we've said, is stretching and it's not without risk. And we just pull out that the key risks to delivery are around the level of cost and productivity efficiency that we're targeting as we exit what's been a very challenging winter and COVID period, and some of the complexity that surrounds our ability to earn elective recovery funding, as there is still some national uncertainty around some of that mechanism. As we described earlier, so our submitted plan is at £27.1 million, but that remains unacceptable nationally, and certainly the Herefordshire and Worcestershire overall deficit is not yet at this point accepted nationally. And so we continue to work across the ICS and with NHS England to explore any further mitigations for that system position. And just a final point to note around the plan, Chair, so it's not within the paper, but in terms of capital funding, there is still some uncertainty around some of the sources of funding that sit outside our business as usual capital allocation, which we continue to actively pursue. And once that position is clarified, we'll be able to fully finalise the application of those funds, so the spend plan against the capital plan, and bring that back for awareness of board.
Thank you, Katie. It's just worth emphasising the point that Richard, I think, raised earlier, and we'll just need to be aware of. If inflation increases to anything like the levels that the Bank of England expect it to, these numbers will not be met purely because of inflationary pressures. But on the basis of the assumptions that we've been told to make, they are what they are. Any questions to Katie? So this is just for noting, isn't it, Katie?
It is, Chair. I think Andrew had a question.
Yeah, saw his hand go up. Andrew?
Yeah, it's just partly a concern I raised last time, but the speed at which we come out of the difficult period we've had operationally we've had over the past couple of months is really critical, isn't it, to achieving the plan that we set out last time, and the length of time we can stay in that period, a period of stability. But also linking the earlier conversation about vacancies not really dropping until October. Again, I'd have thought the workforce indicators improving would be vital to, one, reducing our costs, but two, implementing some of the productivity gains that are assumed in the plan.
Yeah, no, good points, Andrew. Operation Ring Fence is definitely critical. If we don't get the elective recovery work going, that does affect things. Katie, your observations on Andrew's perspectives?
Yeah, absolutely valid in terms of areas of risk that we've identified in the plan, and effectively it's our ability to both deliver elective recovery to the level that we've planned at the pace that we've planned it, and to deliver that at the lowest possible cost. And equally our CPIP plan, so our cost and productivity efficiency plans, will be heavily reliant on an agency reduction expectation, given that that's thematically one of our biggest areas of spend. So it's absolutely where some of that financial risk sits and will need to be carefully managed.
I would like us to look at the business case that Swift signed off last month in terms of thinking about transforming the usage of bank and agency. If you can just make sure you have sight of that with Jeffrey, I think that would be wise. So if there are no other questions, we just take that as duly noted, and thank you for your hard work behind the scenes on that, Katie. And therefore we're on to the elective recovery update. Andrew?
Thanks, Chair. The presentation's in the pack. I'll just point out a few points of note. This is up to the third week of the new financial year. Referrals there continue the trend that we saw in Q4 in terms of around about 20% increase in our 2-week wait referrals, urgents. Slightly lower than we have seen in the previous quarter, only slightly above at 1%, and routine referrals remain down. Overall referrals is down 8% for the first 3 weeks of the year. Just the other point to note is obviously we've already mentioned our challenges with our inpatient waiting list. That continues to grow over the first 3 weeks of the year, but obviously as already previously mentioned, we have plans in terms of our inpatient and our day case productivity as we start to implement Operation Ring Fence as we go into May. Activity up to week 3. Outpatients, both new and follow-ups were below plan. However, I'm pleased to report in terms of for all the obvious challenges we've already mentioned, that for week 4 we are back on plan for the year. So we had a really good week last week, and new outpatients is now on plan. Follow-up is behind plan, but unfortunately, as we already mentioned, our inpatients are behind plan, but there is a plan to recover that as the year ticks on. Imaging, still concerns around echocardiograms, although there is increased work through outsourcing and insourcing there, and non-obstetrical ultrasound still remains a concern. But again, we've got insourcing that is due to kick off there in the month of May. Just in terms of the risk there, the sonographer waiting list, which looks at the priority group for non-obstetrical ultrasound, is at 10 weeks. So although there's quite a big backlog there, our urgent patients are being seen within 10 weeks. MRI continues to be a slight concern. That waiting list seems to grow beyond 6 weeks, and we've got some mitigation in there in terms of some last minute changes to our business planning and use of mutual aid at Worcester. And finally, endoscopy, again behind plan at week 3, but at week 4 we are actually slightly above plan for overall endoscopy activity from month 1. So hopefully we will see that continuing trend of increase as our COVID restrictions ease and we can implement our Operation Ring Fence. That's all I wanted to say, Chair.
Thanks, see some real areas of bounce back after the sort of circuit breaker we had to put in. Questions and perspectives to Andy? Glenn?
One of the objectives nationally is to reduce the number of follow-ups for individual patients and to move to virtual. So when you say we're behind plan on follow-ups, can we just be clear whether that's a good thing or a bad thing, Andy?
Yeah, sure. I think obviously the ask is for us to reduce our follow-up activity by 25%. I think the challenge we've got with such a big backlog and 40% of our patients waiting past their see-by day, we need to implement patient-initiated follow-ups, and we need to look at how we can reduce that as the year goes on. But currently, we've got such a backlog that we need to get on top of that first.
So at the moment, we're the wrong side of the line. Okie dokie, thanks for that update, Andy. Very helpful. So much sharper than the way John Barnes used to do it. You know, it's really encouraging. John always used to put up every individual slide, and but it's great the way you just got to the key points. Thank you for that. So we go on then to the committee summary reports. The first is Equality Committee of the 31st of March. Chris, anything you particularly like to pull out?
Yes, if you don't mind, Chair. Two very positive things. Some excellent results for the teams involved in the Children and Young People survey and the Maternity survey. I don't think they've been brought to the attention of board before. And whilst there's some lessons to learn, there's some really positive things in there, despite COVID, that the teams have worked through. And that's a great credit to the teams and a benefit to our patients. The area of concern remains pressure area care. Following this meeting, new arrangements have been made for a task and finish group to really look at how we're addressing pressure ulcer care, and we look to see improvements in that in the future, but wanted to make sure board was aware. Thank you, Chair.
That's great, Chris. I mean, pressure ulcer numbers are absolutely key as a lead indicator in terms of underlying care, so please do make sure we continue to keep briefed on that. Any questions to Chris on that update, or the anything else from the 31st of March? Okay, we've then got the minutes actually of the 24th of February for information. Chris, is there anything you wanted to put out on that?
No, thank you, Chair.
And any questions from colleagues? So I think then, guys, we're on to any other business. Please raise a digital hand if you have any other business. Can't see any digital hands raised, and I don't think, Erica, we've had any questions from members of the public.
No, Chair.
I would just observe, as I've observed, I think, over a number of months now, at the George Eliot, we have about half a dozen members of the public at every monthly meeting, and the same is true of SWIP. So I am missing members of the public joining us for this session. So if, again, Erica, you can just reflect on what the learning is, that would be good. Okay, team, so we look forward to seeing, hopefully, members of the public at our next meeting on the 9th of June. I suggest, board, we have a 10-minute comfort break, get going into the confidential board at 2:25. See you in that meeting. Thank you very much.